No disclosures, unfortunately. So government worker, right? So I'll start off with a case presentation. This is a patient we saw a couple of years ago, a 19-year-old man who presented with an incidentally found 2.5 centimeter renal mass. And a couple of interesting things about this case. Obviously, this is a young age to present with a renal mass, but it was also unique in that this patient had a lymph node metastasis with a small renal mass, which is something we do not see every day. So we worked this patient up, did germline testing, and he had a germline fumarate hydratase alteration consistent with hLRCC, went on to have surgery and did well. But a word about hLRCC. So it's hereditary leiomyomatosis and renal cell carcinoma. And patients with hLRCC have a few manifestations. Most of them have cutaneous leiomyomas. These are growths of erector pili muscles. Sometimes can be quite painful. People who live in cold climates and get goosebumps can. So I've seen patients who have had to move because of how painful these can be. Women have fibroids, uterine leiomyomas, and it's often quite symptomatic. Many of them need myomectomies or even hysterectomies in their 20s or early 30s for this. And then, of course, what we're talking about today is renal cell carcinoma. And about 15% of patients, in our estimate, develop solid or cystic solid renal tumors. And so we actually start screening at age 8 with annual MRIs. Ultrasound's not sufficient, and CT is too much cumulative radiation. And the type of RCC, we used to call it papillary type 2. In the most recent WHO guidelines, it's FH deficient RCC. But these are high-grade papillary lesions, often not very well circumscribed. So we used to joke in medical school, when will we ever have to know about the Krebs cycle? Well, this is one of those cases. So fumarate hydratase is a Krebs cycle enzyme. It catalyzes the conversion of fumarate to malate. So if patients with hLRCC born with one absent or dysfunctional copy, they lose the second copy and they can no longer perform the Krebs cycle, can't perform oxidative phosphorylation, or obligate glucose users. Furthermore, they have a buildup of fumarate, which is an oncometabolite, has a lot of downstream side effects from that. One note about hLRC, because these tumors are obligate glucose users, they are incredibly FDG PET avid. And this is great for the disease outside the kidney. There's usually too much background in the kidney itself to detect these, but for metastatic disease, it's very sensitive, FDG PET. So a few days ago, I talked about VHL. I talked about how with small tumors, these patients are at low risk for metastasis. But that's not the case for hLRCC. These are two different patients, both who had radical nephrectomies for kind of intermediate-sized tumors, and both developed local recurrences, either in the nephrectomy bed, there on the left, or in the lymph node bed, there on the right. And when we look at our institutional experience, we see in these two columns number of patients and then percent with metastatic disease. We've seen metastatic disease at very small sizes, even in patients with sub-centimeter tumors who developed METs. And by the time you get to a large T2 tumor over 7 centimeters, the majority of them develop metastatic disease. So this is quite an aggressive disease state. So what do we do for advanced disease? Since many patients get here at some point, this is a trial that is about to be reported by one of my colleagues, Dr. Ram Srinivasan. And this is a trial with 2 drugs, bevacizumab and erlotinib. And there were two cohorts in this trial, one for hLRCC, which we'll focus on, and then also for sporadic papillary. And what Ram found is for patients with germline confirmed hLRCC, there was a 72% overall response rate, couple of complete responses in that group, and a lot of partial responses. And in the sporadic cohort, they didn't fare quite as well, only a 35% overall response rate. But you can see on the waterfall plot here that 95% of patients with hLRCC did have a decrease in their tumor burden. And this was about a 19-month PFS survival advantage. One thing for hLRCC, we always have a multidisciplinary discussion for patients with advanced disease, because since we aren't curing most of them with systemic therapy, we always ask, is there a surgical option? And so this was a patient that I met several years ago, had a nephrectomy elsewhere, and just about a year and a half later developed a cystic solid recurrence in the lymph node bed. At first thought maybe it's a lymphocele, but had an enhancing solid nodule in it. And we took this patient to surgery, did an RPLND, and resected this mass, and it was consistent with FH deficient RCC, again, 20 months after her initial nephrectomy. The patient did well for almost 2 years. 21 months later, developed an enhancing lesion in the left adrenal gland. Nothing else on staging, so we did an adrenalectomy. Again, this was consistent with FH deficient RCC. 13 months later, developed a pelvic mass, large, mostly cystic pelvic mass, again resected, inconsistent with hLRCC. 12 months after that, developed lung mets and is now in systemic therapy. So using this sort of surgical whack-a-mole approach, we kept this patient off of systemic therapy for close to 5 years. So looking a little more systematically at our NCI experience with patients with either hLRCC or SDH-B, which is another Krebs cycle enzyme deficient RCC. 24 patients, 8 of these we did not recur after metastectomy, but the majority of them did, 2/3. And some of those went on to have a second resection. But when we look at the time from initial metastectomy to initiation of systemic therapy, we got about 31 months was our median treatment-free survival. So we do think there is a role here to sort of have a multi-modality approach for patients with advanced disease. So to sum things up, hLRCC is associated with an aggressive kidney cancer phenotype. These patients require lifelong surveillance. Metastectomy can be considered for low-volume metastatic disease with the goal of cure maybe in some, but delaying systemic therapy ultimately. And bevacizumab plus erlotinib is associated with favorable disease control in these patients. Thank you so much.